people do we have? Right.
We are live, ma'am.
Good evening and welcome everybody to another session of the DOS Postgraduate Education Program, DOS PEP as we all call it. So as we all know, as of now, we are doing the oculoplasty series on which we are currently on the 7th lecture. And today the topic of discussion is going to be ptosis. Dr. Pallavi Singh is going to cover this topic, and as we all know, ptosis is one of the most important questions that comes as both theory and practical long case question in your exams, and hence needs to be understood in detail. So Dr. Pallavi is going to cover both the theoretical as well as the practical aspects of this topic, and will be highlighting the surgical management of this important topic. And today, for our discussion, we have our panelist, Dr. Nripin Gaur sir, who's an assistant professor at AIIMS Bilaspur in Himachal Pradesh. He's done his post-graduation and senior residency from AIIMS New Delhi in the Department of Oculoplasty and Ocular Oncology. He has over 50 PubMed Index publications, and he's on the editorial board of the prestigious Indian Journal of Ophthalmology, as well as Springer Nature Ophthalmology and Therapy. He's also a reviewer for a lot of ophthalmology journals. And Dr. Pallavi Singh herself is also the course coordinator for the postgraduate education program, Oculoplasty series. And with that, I will hand over the dais to Dr. Pallavi, and you can start sharing your screen.
Thank you so much, ma'am. I am just doing this up. Right. Is my screen visible now?
You can make it full screen now.
Is it fine now?
It's fine. It's fine.
All right. Thank you so much, ma'am. And as we've already done a couple of classes, so there has been a little bit of introduction to what we're going to talk about today. It's still going to be a little bit of a long lecture, but hopefully we'll be able to cover most of the things when we talk about ptosis. So just to give you an overview of what we're going to talk about during the lecture, first of all, we're going to talk about what are the different types of ptosis. Then we will cover how to do a workup, how to do an history and examination from the point of view of an exam case. Any special tests that are done, we'll cover that. And broadly, we'll cover the management of the common types of ptosis that we see. All right. So first, when we talk about ptosis, the first thing that you also see in your history taking and, when the patient comes to you is you think about the onset, whether it has been present since birth or was it something acquired. Now, if it is congenital, which means it's been present since birth, there are a couple of different situations. It can either be simple or complicated. Simple is where you have, simple ptosis. There is no other associated condition. That's when you call it a simple ptosis. Now, talking about what is a complicated ptosis. Complicated ptosis is when you have additional conditions attached along with the ptosis that the patient presents with. Now, as you can see here, the patient has ptosis on the left side. But if you look at the video, if you looked at the video, the eyelid was going up. That was a case of a third nerve palsy with aberrant regeneration. And now this is a patient. If you can see how when he's moving his jaw, you can see that the eye is going up. This is known as Marcus jaw winking phenomenon. So these are the things that you have to look for. Then another complicated condition that can be present since birth is blepharophimosis ptosis epicanthus inversus, BPES, what it's called. And this is like a spot diagnosis. This is something you can also get in your OSCE, like a short case. They'll put a patient with features like this, and you can just see the patient. And because you can see the telecanthus, you can see the epicanthus inversus. So you can figure out that this is what a patient with BPS looks like. The fourth condition, which is not as commonly seen, but also included in the ambit of complicated congenital ptosis, is congenital fibrosis of extraocular muscles. In this case, all the extraocular muscles are fibrosed since birth. It is not progressive. And so you see, people who have had a static condition like this, they will present with ptosis. And if you lift the eyelids, you will see that they also have some form of strabismus, which is mostly exotropia. So those were the subtypes of congenital ptosis, and the other subtype is acquired ptosis. Now that was dividing ptosis on the basis of onset. Now, if we divide ptosis on the basis of etiology, there are 4 or 5 broad types. There is neurogenic ptosis, there is myogenic ptosis, aponeurotic, mechanical, and traumatic. So let's talk about it one by one. Neurogenic ptosis is where there is a nerve problem. The third nerve is the muscle which supplies the levator palpebrae superioris. So if there's a problem with the third nerve, that would be classified as neurogenic ptosis. You can see in the first picture, the eye is down and out and the patient has ptosis. Typically, what you would see in a case of third nerve palsy. This can be congenital or acquired. In the second case, you can see Horner syndrome. Typical features that you see ptosis, meiosis, and hydrosis. You see the side which has ptosis also has a smaller pupil. So this is something you have to keep in mind when you're also doing the examination. Make sure that you're looking at the pupil to rule this out. Talking about myogenic ptosis, myogenic is where the muscle in itself is affected. There is no nerve problem. So it can be a neuromuscular junction problem like myasthenia, or it can be myotonic dystrophy, or CPO. If you see, this is a video of a patient with CPO, and if you see, I'm asking her to move her eye. The eyes are not moving. She has an exotropia, and even when I'm asking her to look up and down, there is hardly any movement of the eyelids. So this is something that you see later on in life. It is progressive. It starts off with a smaller amount of ptosis, gets worse in life, and in a lot of cases, this is also hereditary. When this is combined with other difficulties like difficulties in swallowing or stuff of that sort, then then it would be classified as an oculopharyngeal dystrophy. Sometimes in diseases like amyloidosis, the amyloid protein can infiltrate the levator muscle, so that is also kind of myogenic infiltrative ptosis. Moving on to aponeurotic ptosis is where the levator aponeurosis, which is attached to the tarsus, that gets stretched out or that gets weakened. Typically, most common cause is age-related. As you can see in this person, he has ptosis on both the sides. This is what you will typically see. Patients are like 50 plus, 60 plus. A lot of times they come after cataract surgery because until cataract surgery, they're not able to see. And once, they can see, they realize that one eyelid is drooping. Also, in cases where there's a lot of eye allergies, patients are, rubbing their eye, that also causes a dehiscence of the levator aponeurosis. Or in cases with contact lens use, again, the mechanism is the same, that you're rubbing on the aponeurosis again and again. Talking about mechanical ptosis, again, very self-explanatory. Any mass on the upper lid. In this case, this was a small child with a capillary hemangioma causing ptosis. Another very common cause where you see mechanical ptosis is either lid tumors or neurofibromas. So those are the things that you have to look out for. Then moving on to the last subtype is traumatic. Now, traumatic typically happens because of trauma, but it can lead to either myogenic ptosis, where it is severing the muscle itself, or aponeurotic ptosis, where it is just causing a dehiscence, or if it causes trauma to the third nerve, then also it would be classified as a traumatic ptosis. Then one other type that you have to be very careful of is pseudoptosis. These are conditions where the patient presents with a clinical picture of ptosis, but it is not actual ptosis. So how do we figure out whether the patient has actual ptosis or not? These are the subtypes, and we're going to talk about it one by one. So the first is lack of support. For whatever reason, if the orbital fat is not providing enough support and the eyeball goes inside, then like a shutter mechanism, the upper and the lower lid will, close over the eyelid and it will look like ptosis. So if you look at this patient, if you look at the first picture on the right, you can see that, this eye is looking smaller than the left eye. If you don't have a trained eye, then maybe in first go you will say that maybe she has mild ptosis. But if you look at the worm's view, you can clearly see that she has enophthalmos on this side, which is causing the ptosis. So you have to be very careful. You have to look at all of these things when you're evaluating a patient. The same situation would be with a patient with microphthalmos or phthisis bulbi, anywhere where the orbital volume is less and there is not enough support, which might masquerade as ptosis. The other very common thing that we see is thyroid eye disease related, retraction, which presents as ptosis in the other eye. So now, this patient actually presented to me with ptosis, but she had thyroid eye disease. And if you look at the right eye, typically the upper lid covers the top 1 or 2 millimeters of the eye, but she has her upper lid is, on the upper limbus. So she also has a component of ptosis, but what she was noticing was more of the ptosis, not as much of the retraction. But, how you manage it is a different thing. But if you should be careful and you should note whether the patient has retraction in the other eye. That is one of the common causes. Then if the patient has hypotropia in one eye, for whatever reason, if the eyeball is pulled down, then the eyelid follows the direction of the eyeball. Now, if you look at this patient, if you look at him, he seems to have ptosis on the left side. But if you look at the corneal reflex carefully, you will see that the corneal reflex is showing a hypotropy on the left side. So this patient had a monoocular elevation deficit, because of which he was having a sort of pseudotosis-like picture. So the actual problem was not the ptosis, it was hypotropia. The left eyeball was pushed down. Because of that, the eyelid was also looking like it is ptotic. So in most of these cases, if we fix the hypotropia, a lot of the times the ptosis can get fixed. Then we have other conditions where if there is a brow ptosis, like a seventh nerve palsy, again in this patient, in this guy, it doesn't look like ptosis, but the left eye is looking more open, and that is because there is a compensatory mechanism because he has right-sided facial palsy, and that is causing brow ptosis. And so this, it does not look like ptosis, but you might get a case where sometimes the brow ptosis might masquerade as ptosis. Then the last condition, again, sometimes because of the patient actually has dermatochalasis, which is excessive skin of the upper eyelid, but it may look as ptosis. And also there is a mechanical component because as the skin gets heavier, as the skin is drooping, that is also causing the eyelid to push down. So these are the things you have to, in general, sort of look out for before labeling a patient as a case of ptosis. Now, talking about the history, again, basic things, simply how you do most of your history taking. You want to look at the onset and the duration to know whether it's congenital or acquired ptosis. You want to know, you want to look at the variability. Because if there is diurnal variation, typically patients with myasthenia, and myasthenia presents very commonly in the Indian population. So please make it a point that you ask them that if the ptosis is getting worse at night. Even in cases of age-related aponeurotic ptosis, sometimes it gets worse at night. So those are the things that you have to ask for. Severity, whether the activities of daily living are affected. This is important in terms of a decision-making aspect. If it is something which is hampering their daily activities, then you would want to offer them some sort of treatment. And then, of course, involvement of one eye or one eye after the other in cases of chronic progressive external ophthalmoplegia, you might have, one after the other involvement. Again, then, basically all the things that we talked about in the slides before that, your history taking has to be such that, at the end of the history, you're kind of clear about what the etiology is. So any precipitating factors like any trauma, any previous surgery, contact lens use, allergies, any medical conditions, like sometimes diabetics. If you have uncontrolled diabetes, that might lead to a third nerve palsy, or, hypertension, some sort of an embolic mechanism can also cause nerve problems. So those are the things you have to rule out. Then, of course, you have to ask about jaw winking. You have to ask about diplopia. If you have a sudden onset third nerve palsy, the patient will have ptosis along with diplopia. So you have to ask about diplopia. Dysphagia, in cases of oculopharyngeal dystrophy, they will have problems swallowing or chewing. And tiredness. In general, myasthenia gravis, if it is a generalized myasthenia gravis, they might have tiredness at the end of the day. And then, like I said, CPEO runs in families, BPES also runs in families. So asking about a family history is also helpful. Now, talking about examination. So one is a general examination, what you're doing of the whole face when the patient comes to you, and then we go on to the lid. So talking about the general examination, the first thing you look at as the patient walks into you in the OPD, you look at the chin posture, at the head posture. A lot of times when patients have bilateral ptosis, like there was a small child, in order to look up, they will lift the chin up because they're able to see from their down gaze. So you have to note whether the patient has a chin up posture. Then in general, you have to look at the symmetry of the face. Like if the patient has any syndrome, if there is BPS, then you have to mention those findings when you get a long case that, patient has epicanthus inversus, patient has telecanthus, all of those things. Or if you get facial palsy, brow ptosis and all of those things. So remember, even if you get a case of ptosis, it's not just describing the eyelid, you have to describe the face in general, if there is any bony asymmetry or anything of that sort. Ophthalmos you have to look at. We talked about already why it's important. And then, of course, you have to mention frontalis overaction. So you can see in this side, if you see his brow is lifted up, that's because he's trying to lift the brow in order to lift the eyelid to be able to see from there. So you will see this very commonly. You have to mention in your findings whether frontalis overaction is present or not. And this, I could not get a very good picture of this, but sometimes, with blepharochalasis, which is repeated swelling of the upper eyelid, the eyelid skin and the levator aponeurosis gets thinned out. So you can get what is typically called cigarette paper skin. I could not get a very good picture. And then if anyone wants it, I can always send it to them later if I find some. But this is something you have to keep in mind. To complete the examination, you have to look at extraocular movements. Again, this will be relevant in third nerve palsies, monoocular elevation deficit. Very important, especially in children, to do refraction and vision, because, and this is a common question in exams, that the most common cause of visual deficit in ptosis is anisometropic amblyopia, because the eyelid pushing down on the cornea causes astigmatism more than visual deprivation amblyopia. So from the exam point of view, that's important. Anterior segment, like I said, looking at the pupil is important. Posterior segment, if you have any syndromic involvement, like Kearns-Sayre or on any of these syndromes, so it's important to look at the retina also. Even if you don't look at it, please mention it, so the examiner knows that, this person knows what they're looking for. So I think that's important. Now coming on to the eyelid. So you have to mention the eyelid crease. Now eyelid crease is the faint line that you see when the eye looks down. As you can see in this picture, there's a faint line over here. That is the eyelid crease. So you have to mention what is the position of the eyelid crease from the eyelid margin. Then you have to look for lid lag or lid droop. What lid lag means is that when the patient looks down, if you look in the upper picture, this patient had congenital ptosis, and when she is looking down, the left eye is actually slightly more open than the right eye. This is the eye that she has ptosis in. I'm going to explain about this later. And this patient also has ptosis, but if you look at his eyelid, it is actually lower than the right eyelid. So this is what you call a lid droop, when the eyelid is lower while looking down, and lid lag is when the eyelid is higher. Lag meaning it is not able to follow the eyeball as it should. So it is remaining behind, so the eyelid seems more open. What is the relevance? We'll talk about it later. Again, lag of thalamus, very important. You have to close the eye and see if any sclera is showing. Why this is important? Because after surgery, any lag of thalamus which is there will get worse. So it is important to document it beforehand. Again, all of these questions are, it's important to know why you're looking at something, because that's what examiners ask. Ki lag of thalamus dekh rahe hain, to kyun dekh rahe hain? Because it might get worse after surgery. So it's important to know what it was. Now, talking about Bell's phenomenon, so I'm not going to go very extensively over examination, because Dr. Akruti's lecture on eyelid examination was excellent. But this is briefly how you look at Bell's phenomenon. Again, this is important. Why? Because after surgery, the eye will remain open. So you want to make sure that the patient has a good Bell's phenomenon, and this is the grading of, Bell's. You can take a screenshot later. Again, you have to look at eyelid retraction of the other eye, just to note, if it is pseudodosis of some sort. We talked about Marcus gun, third nerve, Duane's retraction, all of these things, So the extraocular movement examination and ptosis goes hand in hand. Then last but very important thing, you have to look at the corneal function. Again, if in your long case you don't have the time to look at it, please make sure that you mention that you've looked at it, because if the patient has any pre-existing dryness, that dryness will only get worse after surgery. So you want to make sure, at least you want to make sure that your examiner knows that this person knows that this is one thing I have to keep it in, I have to keep in mind. So you look at tear breakup time, you look at Schirmer's test. Also, you look at corneal sensitivity. In cases where you have keratopathies, like this, any nerve problems, fifth nerve problems, where you might get a keratopathy because of that, that will have worse outcomes for ptosis, So those are the things that you have to keep in mind. Then again, I think Dr. Akriti did an excellent job, so I'm quickly going to go over these slides. MRD1 is the distance between the corneal reflex and the upper lid. MRD2 is the distance between the corneal reflex and the lower lid. All of these things are things you have to mention when you're doing a ptosis examination. MRD3, again, feel free to take a screenshot. That's why I've got the whole thing written. Is the distance between the ocular reflex, the ocular light reflex, not the corneal reflex, and the upper lid when the patient is looking up. Now, this is relevant in cases where the patient also has a concomitant vertical squint, like in cases of monoocular elevation deficit or superior rectus palsy, anything of that sort. So not very commonly used, but examiners like to ask, what is MRD3? And it's given here. Then, of course, then you have another one, which is margin limbal distance, which is essentially the same as MRD3, but you are not checking the distance from the ocular reflex, you're checking the distance from the lower limbus to the upper lid in up gaze. This is used to calculate the amount of levator resection we are doing. Palpebral fissure height, MRD1 plus MRD2, that's fairly simple. Margin crease distance, when the patient is looking down, the distance from the margin crease to the eyelid margin. What you need to know that it is shorter in males and it is longer in females. That's typically the female anatomy. So that's one thing you need to know. And also, if this skin crease becomes very high, that means that a dehiscence has happened, an aponeurotic dehiscence has happened. Again, tarsal platform shows the same thing that we saw in the last slide, but when the patient is looking straight ahead. So it is the distance between the lid fold, the skin fold and the lid margin. Not very important from the exam point of view. Now, how will you look at the levator function? Again, go back to Dr. Akriti's lecture, but we're going to talk about, we're going to play this also over here. So you block the frontalis, and then you ask the patient to look down, and then you ask the patient to look up, and you can use a scale to measure the excursion of the levator. And so this is the, by and large division, poor, fair, good, normal. So this is how you have to do it. Another test examiners like to ask, it's called ILIF test. We've rarely ever done that, but in newborn infants where they have congenital ptosis, one of the ways to know whether the levator function is good or bad is when you invert the eyelid. If it pops back on its own, then the levator function is good. And if it doesn't, if it stays everted, then the levator function is poor. Now, why this happens is because in congenital ptosis, the levator muscle is dysplastic, which means it is not formed properly. So between the muscle fibers, you have a lot of fat. So if it does not have the normal elasticity that a muscle has, it will not pop back into place. And that's why you do the ELIF test to check for levator function in newborns. Other tests, just eyelid tests in myasthenia. Before I start the video, I want you to listen to what I'm saying. On the right side, this patient has, ptosis affected by due to myasthenia gravis. And when she's looking down, when you ask her to look up, there's a little bit of a twitch. That's what you call the Cogan's lid twitch. And we'll play this so you can see it. Typically seen in cases of myasthenia. Again, you see when she looks down, and then when she looks up, the eyelid twitches. So that is what you typically see in myasthenia. Most of these videos I've taken off of YouTube so you can see them. This is a beautiful video demonstrating Herring's law from one of my good friends, Dr. Stefania. She was kind enough to give it to me. Again, I would want you to listen to what I'm saying first. Don't read what's on the screen. Listen to what I'm saying. So Herring's law is the law of equal innervation, which means that there is equal amount of innervation to the ptotic lid and to the normal lid. So because the brain is trying to lift up the ptotic lid, what happens is that it lifts up the normal lid also, right? So if you take away the stimulus of ptosis, then that extra innervation to the normal lid goes, and if there is any ptosis, that is visible. So if you look at it, the right eye has ptosis, and the left eye goes up. But when you lift the right eye, that extra, innervation is gone, and the ptosis becomes apparent in the left eye. This is very important in cases of bilateral ptosis because sometimes it might look like the only one eye has ptosis, but the other eye also might have mild ptosis. So at least you should know in your head that this is the test we do to check for, whether there is any ptosis in the apparently normal eye or not. Then again, fatigue test used for myasthenia gravis. You ask the patient, you check the MRD1 in primary gaze, and then you ask the patient to look up, and the muscle gets fatigued, and then again you measure the MRD1. Essentially, you're trying to bring on fatigue and see if the muscle becomes ptotic. Ice pack test, very important test, have to do in most of the patients that come to you with acquired ptosis. Even if they don't give a history of variability, you can take an ice pack, put it on the eye for 2 minutes, 2 to 5 minutes. Some people, it varies what the time you should keep. But you can see this patient presented with ptosis. And then after, applying the ice pack, the ptosis resolved by almost 50%. If it is something as positive as this, you're pretty clear that it's myasthenia. This is a clinical test. Now, what is an actual test to you confirm that this patient has myasthenia is tensilon test, where you essentially give 2 milligrams of edrophonium to the patient. And because it activates your acetylcholine receptors, the ptosis will resolve. Very important to do this with the anesthetist because it might lead to bradycardia. These are all questions that your examiner might ask you. So please remember that, tensilon test you cannot do on your own in the clinics. Then phenylephrine test. Now, phenylephrine acts on your sympathetic receptors, and the Muller's muscle. If you go back and read the anatomy, the Muller's muscle, which is, which lifts up the eyelid, has a sympathetic supply. So giving a drop of phenylephrine will act on that Muller's muscle and cause it to act, resolving the ptosis. So if you look at the upper picture, she has ptosis. The second picture is when we put in a drop of phenylephrine, and that ptosis seems to have resolved a little bit. Why? Because this drop is acting on the Muller's muscle. And why this is important? Because this can give us an indication of how this patient will respond to surgery. And so the last picture is after surgery. The patient underwent Muller's resection. And so that's why you do this test perioperatively. Now, that lid lag and lid droop thing, I don't know. I think in RPC, this was, and Dr. Nirpain was one of my SRs. So he was one of the people who had taught me this, that three differences that are important between congenital and acquired that you should know. Is the first thing is that in congenital cases, usually if the patient has severe ptosis, lid crease is absent. And in acquired cases, you will find a lid crease present. And the most important point is that the degree of ptosis in congenital cases is commensurate with the levator action. What that means is that if the patient has very severe ptosis, their levator function will be poor. You can be very sure of that. And if they have mild ptosis, the levator action will be good. Whereas in acquired cases, mostly it is because of dehiscence. If the ptosis is severe, even then the levator action can be good. I would change that to I would change acquired to aponeurotic, because you can have acquired third nerve also. So I'll change that, but the ptosis might be severe, but the levator action will be still good. And lid lag would be present in congenital cases. Now, why does lid lag happen? Again, we go back to the etiology that in congenital cases, the levator is dysplastic. So it doesn't contract and it doesn't relax also. That is why when the eye is looking down, when it should relax, it is still not relaxing and you get that lid lag. Okay, so the diagnosis basically should contain all the things we talked about. When you make a final diagnosis, you write whether it's congenital, acquired, unilateral, bilateral, simple, complicated. If it is complicated, why is it complicated? Does it have Marcus gun, BPS, whatever? You have to write the levator function, good, poor, moderate. You have to write how the Bell's phenomenon is. And if there is an etiology, like if it is traumatic or if it is, myasthenia gravis, then you have to mention that also. Now, moving on to treatments, broadly, it's mostly treated surgically, but there are certain non-surgical treatments for some situations. Like in cases where you have a very mild ptosis, you can use botulinum toxin. This is not mentioned in textbooks per se, but these are like additional things. If any examiner asks you, if you can inject botulinum toxin in the orbicularis muscle. Now, orbicularis closes the eye. If you relax that, the eye will open a little. So for very mild cases, you can give botulinum toxin in the orbicularis muscle. You can give, again, for mild cases of ptosis, you can give oxymetazoline drops. This also acts on the sympathetic muscle, the Muller's muscle, essentially working like phenylephrine. Upneek, this is a drop which is not available in India. Again, if examiner asks you what are the other things, new things that are happening in ptosis. Crutch glasses, patients who have severe ptosis, but they have very poor bells like CPEO or third nerve palsy, where we cannot do a surgery, you can give them crutch glasses that will help them to see better. Now, talking about surgical decision making, so what are the factors? Again, when it comes to deciding what surgery you do, you have to decide what is the severity of ptosis. You have to decide you have to see what is the levator function, how the Bell's phenomenon is, and if there is any associated condition. So this is, by and large what it is, that if the levator function is good and the patient has mild ptosis or aponeurotic ptosis, then you can get away with a Muller's muscle conjunctival resection or an LPS procedure. If it is moderate, 4 to 10 millimeters, mostly you want to do an LPS procedure, which is a levator resection or a levator plication. Rarely you might do a frontalis but if you're not very keen on LPS, but severe cases, you mostly do a frontalis sling. So again, this is also a summary. You can take a screenshot, which is essentially saying the same thing. What you need to know, if the levator function is very good, then you can do a Muller's muscle or a Fasinella servat. And if it is moderate, mostly we go for LPS procedures. In severe cases, most of the cases you go for frontalis sling. Again, this is for screenshot taking. This is, Cutler Beard was a big oculoplastic surgeon who basically talked about how much levator resection we have to do for the amount of ptosis. It's very difficult to remember, but if someone asks you, you can give them the name. Again, Burke's rule is what you can take a screenshot, but basically it talks about that at the end of levator surgery, where are we going to leave the eyelid position depending on the levator action. So if it is a poor levator action, you want to overcorrect it a little because it will fall. And if it is good levator action, you want to sort of leave it at the position of the cornea because it is going to rise up. These are, typically they don't get to this, but these are for additional marks. Now, talking about Muller's muscle conjunctival resection. This is a surgery where you are essentially using the posterior approach to resect the Muller's muscle. Facinella servat is a modification of this where you're also taking out a piece of the tarsus. So we're just quickly going to go through the surgical video. You look at the eyelid, you invert the eyelid using a Desma retractor, and then you mark how much of the conjunctiva you want to resect. The conjunctiva and there's the Muller's muscle below it. So typically we do 4 millimeters. You lift up the conjunctiva and that has the Muller's muscle below it and you apply the Putterman clamp, right? Because this is the amount of muscle that we're going to resect. And then you pass a suture at the base of the clamp to make sure that that muscle is resected, to make sure that you've tied the muscle. So in this case, we're only resecting the Muller's muscle and the conjunctiva. Along with this, if you take out a piece of the tarsus, that will become like a Facinella servat, So in Facinella servat, they, sometimes don't use the clamp. So there are different variations, but essentially what you need to know that for mild procedures, this is what we're doing. We're either doing an MMCR or we're doing Facinella servat. So they've tied the suture at the bottom and then they're going to remove the clamp and they've cut off the muscle. So they've tied the muscle at the bottom of the clamp and whatever the resected tissue is, they've removed it. So that's how an MMCR works. Talking about levator resection. Now, levator procedures are two types. One is levator resection, the other is levator plication. Resection is when you are cutting off a part of the levator muscle. And plication is when you're not cutting off a part of that muscle, but you're just tying that muscle to the tarsus. I'm going to show a video of levator resection because that is typically what most examiners talk about. You want to mark the eyelid crease. Then you want to put the stay sutures. He's divided the lid crease going through the orbicularis, and then you dissect and basically isolate the levator muscle. These are all Dr. Santosh's videos from YouTube. You can take a look. And then what he did basically over there was, if you look over there, he everted the eyelid and injected xylocaine in the conjunctiva. What that does is it separates the Muller's muscle from the levator muscle, which is on the top. So he's done that. And, then he's isolating the levator muscle, separating it from the Muller's muscle below and from all the orbital tissue up. You can see the fat and everything. So he's separating it. He's separating it up to the Wittnall's tubercle. Now, depending on how much resection he wants to do, he's going to pass a suture over there and then tie it to the tarsus. And so how much muscle we're resecting, it will depend on that beard thing that I had showed you earlier, and on, he's talked about Burke's rule also. So once he's tied that muscle to the tarsus, he's removing the excess skin. So this is what levator resection is. What you do in levator plication is just that you don't remove this muscle. You're just, taking it and like folding it. That's what basically plication is. Essentially works for the same sort of situations. Now talking about frontalis slings. Frontalis slings are there are two ways to do it, what we see in textbooks. One is the Crawford double triangle, where both of your incisions are just above the brow and you're making basically two triangles with this, or you have the Fox pentagon where you have one incision at the top, right at the brow. So mostly, again, I mean, it depends on the surgeon's preference. What are the sling materials we can use? In small kids, you can use ethibond as a sling material. Silicone is what is most commonly used in practice. And then you can also use fascia. Fascia is your own tissue, so it is better, it lasts longer, and lesser chances of any reaction. You can use either the fascia lata from the thigh, or you can use temporalis fascia from the head. So this is again Dr. Hunavar's video from YouTube talking about frontalis sling. You're marking the eyelid crease and he's doing a fox pentagon. So he's made two markings above the brow and then there is one at the top. So you want to pass stay suture and then he's made stab incisions in all the 5 places where we want the sling to go. And in the top, he's creating space for the sling to go in. So this is the sling needle. And essentially, we are just going to pass it in the way which was shown in the diagram in the slide before. So you see how it is, it's a pentagon. It's got 5 anchor points. And once we pass that, we titrate and we see how much we want to lift up the lid, right? And once you've decided how much we want to lift up the lid, you put it in that sleeve and then you essentially bury it in that space that he had made earlier. Now, one important thing also is that because these patients will tend to have more eye opening after surgery, especially when they sleep at night, you want to use a reverse frost suture. Again, important thing from the point of exam to know that it's, what do we do to protect the eye at the end of the surgery? We can apply a frost suture. Now, just one slide each about different types of ptosis. Marcus gun ptosis, again, Dr. Akriti had done a good description of the severity. Now, so if the Marcus gun, which is the jaw winking, is mild, so if the patient has only about 2 millimeters of jaw winking, then you can treat it like normal ptosis. You know, whatever the levator action is, and whatever we discussed beforehand, you kind of treat it like that. And then you tell the patient that the jaw winking might increase a bit because this syn kinesis is happening because when the mouth is moving, when there is a action of the 5th nerve, the 3rd nerve is getting activated. So if we strengthen the muscle, that that syn kinesis will increase. So that is something you have to tell them. In a case where it's moderate, the winking is between 2 to 5, you discuss with the patient what is bothering them more. If the ptosis is bothering them more, then we can do only like a normal ptosis, and the jaw winking will increase. And if the jaw winking is bothering them more, then we'll have to do something more severe, which is what we do in severe cases. Essentially, what we do is that we remove the levator muscle so that there is no synkinesis, and we attach a frontalis sling, which means that the brow is lifting the eyelid. There is no role of the levator muscle in that. In BPS treatment, most of the cases, we do a frontalis sling, that is our surgery of choice. Now you can do it as a 2-stage procedure or you can do it as a single-stage procedure to treat the telecanthus and epicanthus at the same time. What are the complications of surgery? Just to go over it: undercorrection, overcorrection, cosmetic problems, asymmetry, eyelid notching can happen. If you have opened the eyelid too much, if you have not applied a frost suture, if the patient is not using their medications, the cornea may remain exposed. You might get exposure keratopathy. That is something that you have to look out for. Suture granuloma might happen, especially in cases of slings if you're using an ethibond suture, or even in cases of slings, you have to be very careful because you're putting a foreign body. So very important to give them antibiotics. And then this is just, I'm not going to talk about this, but I just wanted to include this maybe from the point of view of SRSHIP exams, or even in exams, what are the syndromic associations? You can take screenshots. Horner's myasthenia, we already know about. Kern-Sayre is important. You have to look at the retina. Then BPES, Noonan syndrome, you have to know about. If you have a patient with associated short stature, developmental delay, make sure that you're thinking about these things. Oculopharyngeal dystrophy and Marcus Gunn, we talked about CFEM, we know CP, all this. And then you have these 3 syndromes that we didn't talk about yet. But just as an overview to talk about, to sort of finish ptosis, if you're doing really well in your viva and if your examiner wants to grill you or not. So I think that's the end of it. Yeah, I think we finished in good time.
I think that was a really comprehensive overview on this topic of ptosis, although it looks very simple when you're dealing with such patients, but the questions can be very complex and examination can be really difficult. And sometimes you often miss, simple, subtle points, and then the examiner catches you in and you're in a fix. So, Dr. Nripin, so over to you for further discussion.
Thank you, Dr. Pallavi.
Yes.
That was a very nice and exhaustive presentation. You covered entirely right from the classification to the surgeries to the examination, everything was very well covered, and even the recent advances. So I had a few questions from you. You just told that there's a nomogram for this kind of surgeries like Buckey's method, Beard's method we use. So while doing resections and while doing placation, do you follow the same nomogram or do you have a certain other option for like titrating the surgery?
I think, sir, initially when we were doing plications, when we started doing plications there, we were using the same nomogram. At least I still kind of use the same nomogram, but that also becomes like, this is from the point of view of surgery. I don't think we follow beards also very, very closely. Just in different surgeons' hands, I think different things work. But if anyone asks, I mean, from the exam point of view, I would say for plication and resection, it would be the same, or maybe I would do a little more plication. I don't know. So, what do you think? That because resection in essentially is a little stronger because you're cutting off that muscle and you're attaching it. With plication, like with like what you do with plication is essentially you're just folding it. So
Yeah.
you may add 1 or 2 millimeter extra per millimeter of ptosis, I think.
Yeah. And another thing regarding the supramaximal plication. So how far do you go in deciding the maximum amount of your surgery regarding vis-a-vis with resections and plications?
Vitnals, up to the vitnals, and if definitely up to the vitnals. So supramaximal would be going up to the vitnals ligament, dissecting all the way up to the top. You can see that white line and just doing that.
So any other recent advances you would like to tell? Like, more recently, AI is also coming in a big way. So has that any role in deciding the amount of surgeries as of yet?
I don't know yet, sir, because I feel like it's also a little surgeon dependent. AI becomes then like a whole new sort of realm where some things may work better in my hands. Like I still tend to do supramaximal plications. Actually, I don't do resections.
Okay.
Supramaximal plications, even borderline cases where other people would probably do a sling, just because I feel that it's more natural because you would have more of a lid lag. But I'm not sure. I don't know if you have any experience with uh, you know AI and things that can be done with it.
There are few models. Basically, they are like not very well in clinical practice right now. And another thing, one kind of surgery that like I think you have not told is Frontalis flaps. Which,
Yeah,
like
yes.
so, any experience regarding those Frontalis flaps?
I don't I think I just did 1 or 2 cases, but for the benefit of the students, I think we should just describe it. So frontalis flap is again I wouldn't say it's a new technique. It's something which has been around, but it just keeps getting in and out of fashion. So essentially, what you do is it's like a sling, but you use the frontalis muscle as a sling. So you isolate the frontalis muscle from here. You make an eyelid crease incision, go all the way up down, isolate the frontalis, pull it down, and attach it to the levator, and use that as the sling material. So you're essentially using autologous. It's autologous material. It's also your autologous muscle from that area. So it is theorized that it works better. How much it lasts, it's a more advanced question, but definitely I think all the students should know about it. Sir, if anything you would like to add to this, this is my understanding of what frontalis flap is. I've
Yeah, I
just
think
done,
you are right.
yeah.
And one of the complication associated with the surgery was a lot of post-op edemas and inflammation compared vis-a-vis to resections and plication.
Right,
The
because we are dissecting this whole area as compared to
and
just,
anything about because as students you'll be getting cases of third palsies and all. So where we have dose toting component also. So how long do we wait for like any surgical maneuver or anything like that?
6 months at least is at least what we used
Yeah,
to
so this is a important thing that we wait for
yeah.
around 6 months for any kind of.
In fact, for
So
traumatic also, I remember when we
yeah,
used to get patients in RPC, anyone who would even present with a aponeurotic ptosis after trauma, we would ask them to wait at least 6 months, because sometimes it rejoins and then the lift, the eyelid lifts on its own. So I think, we can wait that much.
And regarding aponeurotic ptosis, I told that we just reinsert the inserted this LPS. So many times what we see that there's a lot of thinning and you won't be able to differentiate like whether there is a complete dehiscence or not. So what are the things you do like, to distinguish?
I think
How would you manage these patients?
Yeah, so dissection, so again, in this case, anatomy is important, understanding what the tissue planes are. So going from the top to the bottom, you have, from anterior to posterior, you have skin, orbicularis, you will have septum. When you break the go through the septum, you will have the orbital fat. And then the aponeurosis is white. So I think that is one of the important things to see, that when you're dissecting here, if you're not seeing like a nice uh, white or pinkish kind of a aponeurosis, then you want to dissect up and then pull the aponeurosis down, because sometimes the aponeurosis after dehiscence, it goes up. I don't know. So do you have any other pointers? Because I'm sure you would have more experience about how to.
Because I think like what we used to do a minimal placation wherever we could not see the entire disinserted band. So I remember Dr. Neelam being like around 4 or 5 mm. She used to say that just add some placation to it.
Hmm.
So
Rather
this was
than
the thing.
just reinserting.
Yeah,
Yeah.
this
Yeah.
was it. But it
So
all
you
depends on the clinical experience and surgeon to surgeon.
yeah. But
So
any
I
other
think
tips from exam point of view, sir, that you would like to offer to the, because ptosis is an important long case
important
that
because I think
comes.
you have covered each and every aspect of the examination point of view. So most commonly, what the examiner like to ask is the basic understanding regarding classification. So classification is important, and then examination point of view. So what they ask is MRD1, MRD2. As a resident, you should be knowing these things. And then sometimes they'll follow it up with MRD3 just to confuse because it is not mentioned in many books.
Yeah.
So, and apart from that, the difference between the acquired ptosis and congenital ptosis. So these are quite important. And even the phenylephrine tests. So tests are very important from exam point of view. And surgery like if the viva is going very well, they can ask us steps of the surgeries. Rest, I think it was very well covered, and you laid the stress on individual points where, like you have already highlighted the points wherever the from examination point of view, from resident point of view.
So I think,
So, are there any questions from the audience?
ma'am, you're muted, I think. Ma'am, you're muted.
With that, we'll come to the conclusion of this class. I think we have had a very nice discussion, and thank you, Dr. Nrupan sir, for sparing your invaluable time with us. And Dr. Pallavi, you've done really a great job and covered this topic so really well, and we're really thankful to you. So with this, we come to the end, and the next class, we are going to shift to now the lacrimal drainage system, and we'll be discussing the anatomy, physiology, and congenital in LDOs. And I think Dr. Adit is going to take that next lecture on 5th of September. That is going to be a Thursday. So looking forward to your presence. Thank you, Dr. Nrupan. Thank you, Dr. Pallavi.
Thank you, Dr.